So it would be lower limb neurological examination. Obviously, one of the things that we should do is while we are outside the station, while reading the candidate instructions, we should be planning what we're going to encounter inside the station. So since this is a neurological examination, this is the format that we are going to take. So that's very, very important. Before you enter it, you visualize this all together. That's why, for example, in my system, it's the notes are prepared in that particular way. You should be visualizing this before you enter the station. If you enter the station without any plan, then it's a bit difficult. You will get confused if something happens and you freaks out, and then all things go down the drain. Right? So let's start. So preparation, we're going to wash our hands and then introduce myself. Hi, my name is Mieta. I'm one of the surgical doctors. I'm going to examine, sorry, before we proceed that one, I'm going to identify the patient. Can you please tell me your name and age, please? Or name and date of birth, name and hospital number, doesn't really matter which two, but you must confirm two. And then if the patient's wearing a wristband, I'm going to have a quick glance at the wristband as well. Next, I'm going to explain, I'm going to examine your knee. And sorry, I'm going to examine your legs up to the knee. And this will involve me looking at it, feeling it, and then moving, doing some special maneuvers. For the purpose of the examination, I'm going to ask you to take off your shirt. Oh, sorry, beg your pardon. Take off your trousers, but you can keep your briefs on. Usually the examiner will step in and say, no, don't take off the trousers, just exposed above the knee, and that's enough. And then we're going to say, I'll have a chaperone with me throughout the procedure for your privacy and comfort. Is that all right? Do you have any pain at the moment? And then I'll be ready to start the examination. The easier version of this station is there will be a couch. And then you can ask the patient to get up, walk, do the maneuvers, come back, ask the patient to lie down on the couch, and then do the rest of the maneuvers. That's the easier version. But I've given the hard version of the station where you will have 3 rigid chairs, no reclining, nothing much. Examiner will be sitting in one, the actor will be sitting in the other, and the third one for you. Right, so let's go with that harder scenario. So I'm going to start with the inspection. I'm going to have a quick glance around the tables, if there is anything, like any medications and such. Plus, if the patient's walking with any walking aids, like crutches or Zimmer frames, I'm just going to have a quick glance at it. And if the patient's wearing any particular special footwear or special shoes or the special boots, I'll take note of it. The next, I'm going to assess the gait. So first of all, I'm going to ask the patient, are you able to stand up? And I will be standing up with the patient, obviously. And then I'll ask the patient, are you able to walk? If you can walk, can you please walk along towards the door? Take a few steps. Don't worry if you become unsteady, I'll be walking with you and I'll be there to catch you. And then we will be walking while I assess the gait. And this gait obviously would be, what type of gait do we expect for the common peroneal nerve injury?
High stepping gait.
High steppage gait. High steppage gait, because the patient has got a foot drop, meaning inability to dorsiflex the ankle. So if they don't lift it up higher, that ankle will the foot will be dragging on the ground. That's why they have to lift it up higher. That's something called high steppage gait. Afterwards, I want to ask the patient to come back and then sit down, or if they're able to stand without any problems, then I'm going to assess the scar, hair loss, muscle wastings, mainly for both knees. And whenever I go to the side or to the back of the patient, I'm going to take permission from the patient. And no surprises in the examination stations. I'm going to continuously communicate with the patient. I'm going to look at your knee and the leg and the foot. Now I'm going to go to your side, going to look at it, and I'm now going to go to the back and then look at your knee and the calves as well as the heel as well. So I'll be looking around. And if there is a couch, afterwards, I'll ask the patient to lie down, or if there is no couch in this case, so I'll ask the patient to sit down. And then afterwards, I will check the heel and the sole carefully as well, because that I haven't really seen it since the patient's standing. So there will be a scar on the lateral side of the knee, usually around common peroneal nerve, passing through the fibula. So what would be the anatomical landmark for common peroneal nerve?
Fibular head.
Fibular head around.
It's not the head, unfortunately. Neck
Oh,
fibula,
Fibular
neck
neck.
fibula.
Fibular neck.
Classically, it would, well, even if you say head, you would be able to feel it and then find it. But for the purpose of surgical exam, it would be the neck of the fibula, would be such surgical landmark for the common peripheral nerve injury. So you would expect a scar towards the neck of the fibula on the right side. And then the next thing. So neurological examination is inspection, sensory, motor, and coordination. So we've done the inspection. We're going to go with the sensory. Going to feel the temperature. And the temperature, I'm not going to go too much in the details, just going to use the back of my hands and then feel quickly, comparing both sides with the thigh, if it's exposed, or between the two legs and with the foot as well. Pinprick and touch. So for the pinprick, I'm going to use the neurotip. I'm going to ask for a neurotip. For the touch, I'm going to use the cotton ball. Basically, these two procedures are identical. So I'll just explain in one go. So I'll pick up the neurotip and explain it to the patient. Whenever you introduce a new thing, you have to explain it to the patient, all right? So this is a neurotip, and obviously you will not be able to use the sharp end because the examiner is going to stop you. So this is the neurotip, and I'm going to touch you with the tip of this pen, and this is a blunt end, it shouldn't hurt you. Then I'm going to ask you to close your eyes, and you please let me know if you can feel it, and if you can feel the same on both sides. So this is how you're going to feel it. I'm going to touch the breastbone. You can touch the head, breastbone, or anywhere in the midline that's acceptable. But some people don't like being touched on the forehead. That's why I don't use the forehead. I will use the breastbone. Now, afterwards, I'm going to ask the patient to close their eyes. Very important thing is not only loss of sensation, but also reduced sensation on one side. So what I'm going to do is I'm going to take the nerve distribution approach, meaning I'm not going to go with the dermatomal approach. Let's see if in the external links, if there is no the nerve distribution chart. Well, it's in another station. But anyway, so nerve distribution approach, mainly, we have to briefly know from the knee downwards, which nerve distributes, which nerve innervates which area. So from the medial side, which nerve innervates the leg?
Saphenous nerve of the superficial femoral.
Great, saphenous nerve. Saphenous nerve is a branch of?
Femoral nerve.
It's a nerve, it's a branch of femoral nerve. In other words, it's a continuation of the posterior division of the femoral nerve. So that's a very good point, because since we are worried about common peripheral nerve, which is a branch of sciatic nerve, saphenous nerve reference point should become a very good one. So saphenous nerve distribution starts from the medial side of the knee all the way down to the leg and the foot, up to which point?
Up to base of the big toe.
Usually MTP joint towards the medial side. So which nerve supplies the medial side of the big toe?
Superficial peroneal nerve.
That's the correct answer. Superficial peroneal nerve supplies the medial side of the big toe. Very important. Together with the whole dorsum of the foot, except
First
interdigital cleft.
Lateral.
what space is supplied by?
Deep
Deep peroneal nerve. Great. How about the lateral side of the foot?
Superficial peroneal.
Sural nerve.
Sural nerve is the answer. Sural nerve supplies the lateral part of the foot as well as the posterior side of the leg as well. And superficial peroneal nerve, in terms of the anterolateral side of the leg, lower half anterolaterally is supplied by superficial peroneal nerve. Upper half is supplied by
Lateral sural nerve. Common
lateral
peroneal
sural
nerve.
nerve. Lateral sural nerve would be the answer. So briefly, from the posterior laterally, that's a sural nerve. Anteriorly, upper half is the lateral sural nerve. Lower half is the superficial peroneal nerve. And the medial side, the whole thing is this saphenous nerve. That is for the leg. For the foot, medial side, pretty much the whole up to MTP joint is the saphenous nerve. Pretty much dorsum, including the medial side of the big toe, except the first warp space is the superficial peroneal nerve. The first warp space is deep peroneal nerve, and the lateral side is the sural nerve. So what I'm going to test are these points briefly. I'm not going to go down in one leg, finish one leg, go to the other one. What I'm going to do is compare this one and the other one. Why am I taking nerve approach? Why am I not taking much easier dermatomal approach?
Because of due to I'm going to
Save
do
time.
focus examination with clue of the scar. I suspect peroneal
What I
nerve
am
injury.
suspecting is the lateral nerve injury, peripheral nerve injury. If I'm suspecting, let's say, the root injury, it would make sense to go with the dermatome. If the root is intact, but the lateral nerves are damaged somewhere, then it would be better to go with the nerve distribution so that I can pinpoint which nerves are injured and which are not. So which nerves would be affected? Common peroneal nerves get injured going around the neck of the fibula.
Superficial and deep peroneal.
Superficial and deep. And
Sural.
sometimes sural nerve could be injured as well. But lateral sural nerve comes out much higher. So lateral sural nerve will be intact, meaning upper lateral half, anterolateral part of the leg usually will be spared. That is, in fact, around the area of the injury. So that is a bit confusing because the nerve is actually injured there, and that area is sensations intact, and that might confuse some of the candidates. But that anatomy is very simple. The lateral sural nerve comes out in the popliteal fossa, or just after leaving the popliteal fossa before looping around the neck of the fibula. So if the nerve's injured there, the lateral sural nerve will be intact. That's simple as that, right? So in this case, either superficial peroneal nerve or deep peroneal nerve, and plus or minus sural nerve could be injured. It could be any of the scenario. So both pinprick and the touch, same thing. I'm not going to do the vibration or proprioception. I will only do these in diabetic foot examinations because this is not a systemic disease that I'm suspecting, and it will be a waste of time. Anyway, if you're going to do the vibration, there will be, let's say there is only one tuning fork. What would that be?
5
You need
to
to pick up only one. Let's say 3 tuning forks available inside the station. Usually it's the 512, 128, and then 256.
256.
Which one are you
512.
going to pick up?
128.
512.
You cannot do vibration with 256 or 512. You will get 0 points. That you must only use 128. Vice versa, you cannot use 128 hertz to test the hearing. You must use minimum of 256 hertz and preferably 512 hertz. So that is for the hearing test, right? And the proprioception, again, ask the patient to close their eyes and then move to joint, and then ask the patient which joint position is that, etc., etc. So, but I'm not going to do this one because that I feel like there will be a waste of time, and I'm not. This doesn't really fit the clinical picture. I want to move to the motor, the tone. How do you check the tone?
Passive movement, assess the passive movement of the ankle
Leg
joint.
roll, leg lift.
Well, there is no couch. The patient's sitting on the chair with a foot on the ground.
By
Normally,
shaking
it
them.
would be easy if you ask the patient to lie down on the couch and then roll the leg or lift up and then drop it. That's what we normally do. But now, can't be done.
Rolling or shaking. Rolling or shaking.
Say it again.
Rolling or shaking.
Oh, you can't roll the leg because the patient's
Yeah.
sitting.
Shaking, then shaking.
Shaking what?
The leg.
Passively move the
How do you shake the leg? I can't visualize it. You just shake laterally, up and down, obliquely. Right. So the answer is no.
passively move the passive movements by
For all tone, power, and reflex, you know what's a trick? The trick is, well, some people will try to lift up from the knee. And if you're a very strong person, that's okay. And especially when the actor is relatively thin person. But imagine if you're a young lady, small young lady, and the actor is 100 kilograms. There is no way that you'll be able to lift up the knee on your own and ask them to rest it on your hand. So the trick is ask them to cross the legs. Ask them to cross the legs and let it hang freely. And then you've got access to do whatever you want to that particular leg. So how do we check the upper limb tone?
We shake their hand and then move it in all directions.
What kind of movements?
Flexion, extension, and
Pronation.
pronation, supination.
Circumduction of the wrist, for example, circumduction of the shoulder, flexion, extension of the elbow. You can pretty much do the same of the lower limb to check the tone as well. So what you can do is circumduction of the ankle. Well, not true circumduction, but dorsiflexion, plantarflexion, inversion, eversion. And then afterwards, if you still would like to do it, knee flexion and extension, all passive, to see if the tone is normal or not. Shouldn't be very stiff, shouldn't be very floppy. The tone should be normal. Next, the power. How do you check the power?
Asking them to move against resistance.
Always against a resistance, very good. And I would normally do it compared to the other.
Yeah, bilateral.
Right, bilateral. But it's okay, I can do it right now, and then I'll ask, since the patient's crossed the legs, then I can do it later on. It's not really a problem. While the patient's legs is crossed, what you need to do is the reflex. Otherwise, it will be very difficult.
Oh, yes.
Reflex, go ahead, and then if the patient's still having resistance, you can ask the patient to pull like this when you tap on the knee reflex as well as the ankle reflex. So where do you look at when you're tapping on the knee?
Quadriceps.
You always look at the muscles contractions, quadriceps, and for the ankle reflex, you look at the calves, not where you're tapping or not at the knee or the movement downstreams as well. Right, very good. And then afterwards, if you couldn't do the power, then you can uncross, ask the patient to uncross the limbs and then do the power as well. Right, so that is the trick. If there is no couch, all you need to do is ask the patient to cross the legs and do whatever you need to do. Afterwards, coordination heel to shin test. This time it's a little bit tricky while the patient's sitting, but still you can ask them to straighten their legs, give command. So what's the easiest and simplest command to give?
Your right heel on left knee.
So your right heel on the left knee, and then the left heel on the right knee, and then what? That's too
Run
confusing.
it down.
Run along the length of a leg.
And
Run along the length of the leg.
Lift it up
Do it
and repeat
Repeat as
after
fast
lifting.
S
as
As
what?
Can you put your right heel or left
So one
heel
key thing is
or
missing.
down?
All the coordination tests must be done as fast as they
fast
can.
as
Burn that at the back of your mind. All the coordination tests, if you ask them to do it slowly, they will still be able to do that, and even in real patients. But if you ask them to speed up, that's when the deficits become very clear. So that's why all the cerebellar examination, especially in the cerebellar examination, you have to do all the movements as fast as they can. So in this case, I'm not going to ask right heel, the left knee, and then too confusing. So I'm just going to ask, doesn't really matter which knee and the which heel, right? So I'm just going to ask them to put one heel on top of the other knee and then slide it down, repeat that movement as fast as you can. And then they should do it at least 2 to 3 times on one side. Do not forget to ask them to switch to the other side. Completion, like to examine cranial nerves examination, upper limb neurological examination, vascular examination, spine, observation chart, and the track chart. Any questions so far regarding the examination itself? Great, so let's go
I
with,
have a question.
go on.
So in case of any examination, irrespective of whichever region you're examining, if you notice a scar, are you allowed to ask what kind of surgery the patient underwent during the examination or not?
The answer is no.
Like, can you question the patient that what is this scar? Yeah, where did you get it from? Are you allowed to do that?
The answer is no, because that will be regarded as the you're taking the history. And if I'm to go back to the slides, well, there will be a thing. And since this is written, some of the examiners will really be pissed off. They won't be happy if you start asking about what side, especially even, right, if I'm to go to extreme, even if the patient's complaining of pain, you're not allowed to ask which knee patient's got pain. It's your job to demonstrate the patient's having pain on that particular side. So it's up to the examiner as well to a certain extent, but normally the answer is no.
Right. Thank you.
Actually, it happened to me in varicose vein examination, and the patient was there was a blister, and I asked about the injury that they had. The patient answered me that he had a rupture varicose, so that will consider as.
So if the examiner is happy, it's okay. It's up to the examiner, to be honest. It's theoretically, you're not allowed to ask any of the things that would relate to the history of the patient. But on the other hand, you could argue, okay, this directly related to the examination. So it's up to the examiner. If the examiner is not happy, they will stop you. Or if the examiner is happy, they won't say anything and then let you do the examination. But regardless, what's going to change, whether you get additional information about this or not? Nothing much going to change with the examination. So rather, I would save that time and then just do the examination. I wouldn't risk the examiner to be pissed off at me. What?
What about in a submandibular gland swelling and I can't see anything? Am I allowed to ask? Could you point out the swelling for me?
Again, that's quite a controversial station as well, and it's up to the examiner. So if the examiner is happy, then that's okay. If not, they'll tell you, okay, stop. You're not allowed to ask the questions. So the short answer is nobody knows, right? And it's up to your luck as well. And you're right, submandibular gland examinations are absolutely normal because these are the actors, these are not the patients. All right, any other questions? All right, let's move on. So give me a few differentials for the common peroneal nerve injury in this case.
Peroneal nerve injury following radiofrequency ablation of varicose veins, fracture head of the fibula, neck of the fibula, prolonged tight plaster cast, knee dislocation or fracture.
Yeah, so you can throw in quite a few things, both systemic and the local causes. Trauma surgery, in this case, obviously the surgery is the cause of the nerve injury, or diabetic neuropathy, being alcohol, excessive alcohol, or radiculopathy, lumbosacral plexopathy, sciatic nerve lesions, multiple sclerosis, sarcoidosis, amyloidosis. These are the systemic diseases that could be affected as well. But make sure you know at least 3 of the differentials. Investigations, what are we going to do? Anyone?
Electromyography and nerve conduction study, MRI of the lumbar spine and bloods, metabolic, alcohol, vitamin B12 folate, diabetes.
Right. So I would normally start from the bloods. So my approach is very simple. Start with simple and blood test, and then go more invasive and more complex group of investigations. But regardless, this is a straightforward investigation. So I'm going to start with a routine blood test. Full blood count, use an ECRP, actually carotid profile, group and save. And if you're worried about the metabolic profile, we can add, as you said, fasting blood sugar, HbA1c, vitamin B12, and folate as well. And the next to the knee and the leg x-rays just to rule out the fractures. EMG and nerve conduction studies, this is the most important test. These are 2 different tests, but they're usually done together. What's the difference?
EMG assesses the response of the muscle, and the nerve conduction is specifically the nerve, if it's conducting electrophysiological stuff.
So in short, the velocity of the nerve. They really look at the velocity of the nerve, whereas electromyography is the contraction of the muscles. So that tests the muscle bulk as well as the nerve muscle neuromuscular junction as well. Right? So these 2 are separate tests, but they're usually done together. And then the MRI of the spine to rule out if there is any of the root problems. What's the management?
Adequate
Ankle foot
analgesia,
orthosis.
foot care, ankle orthosis, physiotherapy, perineal nerve stimulation, or implantation.
So if I'm to
Surgery.
ask you to choose only one, what would that be? In other words, what would be the The only thing, if you are going to choose only one, which one are you going to choose from the management?
Physiotherapy.
Foot care,
Ankle
ankle-
support.
ankle support.
Ankle orthosis or foot ankle orthosis, ankle foot orthosis, I've always said. So the problem with this is the nerves are very good at recovering themselves. Many of the time they will recover, even if it's not to the full extent, they will recover up to a certain extent. The problem is the foot is dropped, and that decreases the quality of life significantly for the patients. All you have to do is put them back in the normal position, and that is using the ankle foot orthosis. As long as the ankle is in this slightly dorsiflex position, it's like normal anatomical position, they won't have any problem walking around, going around and stuff, and they wouldn't affect the quality of life. Physiotherapy, of course, is very important in the recovery process as well. Adequate analgesia, and these are the peripheral neuropathic agents, especially if the patient has got uncontrolled pain coming from that injured nerve. So we can use the gabapentin or pregabalin, SSRIs like duloxetine, or tricyclic antidepressants like amitriptyline, as you can see. Peroneal nerve stimulation implantation. This is more like towards the experimental group of the therapies. It's not widely used, but it's a small box that's implanted around the neck of the fibula, gives out the electrical signals, and helps with the muscle contractions to keep them in slightly dorsiflex position, as well as helps with the recovery of the nerve. Again, as I said, it's not widely used. Lastly, surgery, either nerve repair or tendon transfer surgery. Nerve repair is particularly difficult because many of the time, when you cut something, it retracts into the tissues and disappears. And many of the times, we don't even know we've cut enough. So that's a problem. So if the nerve is cut and found during the, let's say, varicose vein surgery, then nerve repair may be feasible, but usually not. And lastly, tendon transfer surgery, which is very, very rare and reserved for very serious cases and severely affecting the patient's quality of life. What is tendon transfer surgery?
And
Which tendon is transferred to which tendon?
tibialis anterior flexor hallucis longus.
Posterior tibialis tendon.
To
Tibialis anterior.
Bringing from the from the plantar aspect to the dorsal aspect, so the patient get the dorsiflexion.
So you put transpositioned through the interosseous membrane, posterior tibialis to the anterior tibialis, or flexors to the extensors. Do you have any questions?